So I think so I wanted to talk about, COPD, what rethinking about the exacerbation and how we can improve our patient's outcome in patient with COPD exacerbation, especially some of those data that I'm going to show you, and why I choose this topic to talk about in a medicine grand round. So the learning objectives, so understanding the evolution of burden of COPD in Ontario and Canada, and identify the health system barriers to, COPD care, and review some of those new and emerging therapies, including biologies, and explore some innovative care models to reduce readmission. So, does anyone know what's the COPD readmission rate in our system or in Ontario? Roughly
25%.
25%? So close enough. So this is actually in our system database. So you can see from 2024 April I think 2025 February. So that our target is 12.6, but we can see that we are around 20, but some of those months were
Sorry,
down.
we're having trouble seeing the presentation.
Can you see the presentation?
No, it's not up. It says you're sharing the screen, but that's it. It's kind of a blank screen. Like, want to try to reshare it?
Okay, sure. One second. Can you see it now or?
Yes.
Okay, perfect. So basically, can you see that now? So this is actually our COPD readmission in our section. So entire system, it's month to month from 2024 April to 2025 February. In certain months, they're higher in August and November. And, we're unfortunately above target most of the months. And then this is actually, there's, different sites and, color coded and differently. But you can see it, most of ours is above the target for our COPD readmission. Basically, it's just COPD readmission after 30, within 30 days from the index admission. So definitely is a huge burden to our Canadian, our health system. And as you know, the COPD is fourth leading cause of death in Canada. And roughly 20% of 30-day readmission, which is, 1/5 of the patients comes back to us, the hospital system, purely because of the COPD. It's many reasons, I think, especially in our population, some marginalized, a lot of immigrants and everything. So there are many nuances to the readmission. But in terms of COPD in the entire system in Canada or, all the other states, given the aging population, even though smoking status has been pretty steady and some decline, but the COPD burden in our system is continued to grow because of the aging population and even, adjusted to smoking cessation. But as I said earlier, 30-day readmissions are around 20%. And there are more and more data that support and evidence of mortality associated with every admission or exacerbation associated with increased mortality and declining their lung function. And it's significant cost to our system, particularly in our study, one of the studies in Canada here, it showed the COPD specific admission contributed to 57% of the total cost of COPD medical care. So more than half, it's purely for the admission from their COPD patients. And again, it's impact our health system, efficiency, and just burden our system, and it's a quality of care. So that today, so I'm going to focus on how some of those strategies that we can, do to reduce this readmission and improve their overall quality and their prolong their life and improve mortality. The first thing, we focus on inadequate discharge planning. But I'm going to talk about that in a details and what are some of the checklists that we can focus on in terms of COPD discharge. Particularly when we looked at our data, internal data, Friday discharge have increased risk of readmission. Some, other reason is that because of we don't have weekend coverage, the patient to access to care, or some of those healthcare needs, or not able to resume during the weekend. The oxygen or inhalers and home care, and many other reasons we're not, entirely sure. But in across the system is a Friday discharge is a higher risk of readmission. So one thing, probably think about it. And then the inhaler technique and adherence, especially 9 out of 10 patients are their inhaler techniques are poor. So strengthen that is very important. And comorbidities, especially the cardiovascular risk thing, I'm going to show some data to support, and there's a growing evidence that patients with the COPD exacerbation, they are higher risk of having cardiovascular outcome within 30 days. So we'll show some data on that. So how we can mitigate that, so preventing that readmission and access to care and follow-up immediately after hospital discharge. It's another huge barrier and will improve if able to have that access. And then health literacy and socioeconomic status of patients, and older the patients have higher risk of readmission. So there are some of those things that we could, improve our patient care to, prevent those readmission. So let's confirm, first thing, the goal guidelines show up. Some of those checklists will improve the readmission rate. One thing that is, we need to make sure that the diagnosis is appropriate. Not, every patient smoke, every smokers with comes in with shortness of breath is not, COPD. So COPD is a diagnosis by, spirometry or PFT. So we need to prove that they have obstruction. And then the severity it's also important that predicts, probably some of those flare up, how they're going to behave and so on. So first thing is important. And then I'm going to talk about medical therapy, how we can optimize medical therapy and education regarding their disease process and plan early follow-up and then COPD clinics. So the good news is the system is looking into opening our COPD clinic soon. So stay tuned that you will get more details on that. And addressing comorbid disease. Definitely everybody knows that smoking cessation is a huge part of it. And then refer to pulmonary rehab, which is another huge barrier to our care. And appropriate oxygen therapy and non-invasive. These are the subtopic I'm going to cover this today. So as gold is FEV1 FEC ratio is less than 70% or lower limit normal according to the ATS criteria to confirm that's your COPD. So definitely there are if you document the patient is COPD and without the diagnosis purely because they're a smoker and comes in with shortness of breath. So then you increase the diagnosis, maybe some false diagnosis that'll ultimately, document the chart will account for the readmission as well. So I think it's also important to know the diagnosis so that we can appropriately treat. Some mimickers, like whether there's a heart failure, whether we miss an asthma or some other diseases. So I think confirming diagnosis as an inpatient, it's important. And sometimes you can do some bedside spirometry in our system, but in certain sites are difficult to do. So that's an option in patient have no diagnosis prior. And then second, the severity is important in terms of how you approach the patient. Especially, I want you to focus on there's an A, B, and E criteria. So so especially E is in more, risk of exacerbation. So that's what we're going to focus today. So the criteria is whether they have two moderate exacerbation. That means they have outpatient therapy for COPD exacerbation for steroids, antibiotics by her family physicians or walk-in clinic, or if they are leading to a hospital admission, it's one is enough to cause as a category E, and they are increased risk of readmission. So whenever you see in ED and admitted to their ward and have a one leading admission, and that's count for like they are categorized as E, so they are high risk for readmission. So those are the patients that we're going to focus on. How are the medical evidence? What are the evidence-based medical therapies available for those patients that prevent their readmission? So one thing, if you looked at the group E, they have already, should be at least on LABA/LAMA, and then consider adding ICS if the eosinophil count is more than 300. That is, definite. And then if it's more than 100, it favors to adding ICS. So the triple therapy that and two medications like available is a Trilogy or a Brasserie. So the evidence are, paramount that how those going to help. So think about that when your patients are in the hospital and initiating that, and then definitely at the time of discharge. So once your patient's on focus on right here, and if they're on triple therapy and they are still exacerbating, and then your options are roflumilast if it's FEV1 less than 50 and they have chronic bronchitis phenotype, azithromycin preferred for the former smoker. And then now the new biological agent is approved in USA actually too, but it's still pending in Canada, hopefully by this summer in next few months. So while on triple therapy, they are still exacerbating and they have a eosinophil count more than 300. There are some biological agents promising effect on reducing exacerbation. So again, triple therapy, it's improves, reduce your exacerbation and then reduce your mortality. But there definitely the gap in a real world prescribing, even though it's an evidence-based, and especially maybe your formulary barriers and lack of coverage and insurance coverage and so on. But fortunately, in our system, we have both Trilogy and Brasserie in our formulary. So I think, if the patient is in the exacerbation and the inhalers are not optimized, I think make sure that they at least on triple therapy. Then I'm going to talk about the biologies in coming slides. So why we are talking about triple therapies, it's really huge in to reduce exacerbation and improve the outcome. There's two main trials, impact trials in 2018 at New England Journal. The population basically is a COPD with one moderate exacerbation or severe exacerbation in past year. It's a double-blind placebo-controlled trial. It's reduced 25% of exacerbation than dual therapy. So definitely it improves the reduced outcome and prevents their one-fourth of the patient exacerbation. And then COPD hospitalization and then all-cause mortality. So definitely this is being standard of care at this time. And ethos trial, it's for Brasserie's 2020, published in same population, one exacerbation previous year. It reduced 25% reduction in exacerbation and also associated with reduced all-cause mortality. So those two is at least huge in terms of inhaler therapy. And then always the risk of, we talk about pneumonia risk on these triple therapy, especially with COPD. What are the risk of pneumonia because of the triple therapy? So those two trials, impact and ethos, and impact, the triple therapy has 8%, versus dual therapy is 5%, but in ethos is 3.5 to 4.2. but it's dose dependent. The trials with high dose steroids. But the current approval dose that we have in a formulary, it's 3.5% versus 2.2. But the risk of pneumonia is high in the prior history of pneumonia, or their eosinophil counts are low, especially less than 100. That's probably not an indicator at that point to initiate triple therapy. So if the patient is more than 100, no prior history of pneumonia, I think definitely they would benefit from triple therapy. So it's not only the trial, but in the real world, it's a pragmatic open label real world trial in UK looking at 2,800 patients. They are on compared to fluticasone vilantrol, which is their trade name is Brio. And they escalate in triple therapy when clinically needed. And when they did that, meaning that starting early on ICS, especially those who had high risk and post-exacerbation, there are fewer COPD exacerbation, better symptom control, low rate of hospitalization and ED visit. So it's definitely enough evident for us to think about that. And in the meantime, what's the question will come, it's maybe mostly for respirologists and some primary care, not for mainly for the hospitalist or general internal medicine, but de-prescribing or personalized therapy. There are other trials looking into Wisdom and Sunset, how you de-escalate from triple therapy. Mostly we consider do that when they are like stable for more than 12 months and no exacerbation and their eosinophil counts are low, and not really more than 300. Then, you can wean off the steroids, but the risk is still there. There are small decline in FEV1 in those withdraw ICS and kept them on LABA/LAMA. Some slight increasing in exacerbation, but especially in those have a little bit higher eosinophil count. So I think it's will always looking into that. If they are risk of pneumonia and they have recurrent, then you are some room as long as they are stable. But the declining in lung function is not huge. In Wisdom is 38 ml over 12 months if they withdraw the ICS. In Sunset is 26 ml. But no significant, in terms of the symptom. But as it's possible to withdraw as long as they are stable and low eosinophil count. So when do you consider a biological agent? So when we think about COPD, it's a smoker's disease and some others we thought is all fixed lung disease. We're not going to improve lung function. It's not an eosinophilic disease. That was the previous assumptions or medical school we learned. But I think, when we looked at recently for last, 4 or 5 years, 20 to 40% of COPD patient has some eosinophilic component. And that's account for some of their symptoms, the chronic bronchitic phenotype, or like they're symptomatic despite of their some lung function and their exacerbation. As we know, the lung FEV1 is not a predictor of, exacerbation, but they're different. Some patients are FEV1 70, 80%, they come to hospital many times. Some of them, like we have patients in FEV1 20s, they never exacerbate. So it's not the marker. So we're looking into what the reason for the exacerbation. So there's, eosinophil counts. It's one of the biomarker we look for asthma, but seems like, COPD also playing a role in their airway inflammation. There are two main trials. There are a few other trials looking into it and many other biological agents, but the two main trials, and dupilumab and mepolizumab, their studies are published and then approved, FDA approved in the US for COPD patients. So when you consider a biological agent, especially if the eosinophil count is more than 300, they have 2 exacerbation on a maximum inhaler therapy. So I think these medication would benefits for those patients, especially many reasons that I'm going to show you. So the Boreas trial is looking into diploizumab, which is 300 milligram every 2 weeks. All the patients are on a maximal therapy and eosinophil count on more than 300. And the annual patients are like moderate to severe COPD with exacerbation. It reduced exacerbation by 30% and improved their FEV1 with 160 ml, which is a huge number for a COPD patients who have moderate severe disease. And it's accounted for because of the improved the airway inflammation, their mucus plugging, their airway remodeling. So many data are looking into that. So this is a life-changing treatment for some of those patients have recurrent exacerbation despite of the inhaler therapy. They quit smoking, optimize everything. So this therapy would definitely would benefit those particular patients. And hopefully once it's approved in Canada, so we would able to consider this as a therapy to prevent readmission, improve their outcome. And Metini it's published this year in New England Journal. This is a mepolizumab. It's 100 milligram every 4 weeks. Again, patient with eosinophil count of 300, more than 2 exacerbation a year on triple therapy. It's reduced exacerbation by 20% and also improved lung function. FEV1 is 75%. Compared to diploizumab, the effect on lung function and symptom control less. But there's two other studies on mepolizumab as well. But FDA approved for this eosinophil count of 150 and diploizumab for 300. So we expecting the same here as well. So these two are currently approved. There are other studies. We were involved in, Miranda's trial for looking at IL-33. And then, we are hoping to in study for EMBARK trial, looking into tezolizumab for COPD exacerbation. We're hoping to enroll patient in our assistance system in coming this summer. So, and we talk about optimal medical therapy, the triple therapy, at least for those who exacerbation and increase eosinophil count, high eosinophil count. And we talk about some of those biological agent in pipeline, hopefully soon, to help those patients burden to our system. And educations on those patients on the disease and inhaler techniques and so on. And in the checklist, we talk about plan early follow-ups and then COPD clinic. So if you look at that, so what COPD clinics and early follow-up can impact on their care. So early post-discharge within seven days, it prevent the gap in care transition and, and then optimize the inhaler, technique and review their inhalers and optimize their medication if they are not on triple therapy and if it's appropriate, and looking in their side effects and other profiles. And also biological agents, and they're already on triple therapy, they still have symptom burdens and they're still flaring up, applying, getting an approval for biological agents. Those are other things. And then looking at their CAT score and MMRC and the symptom control. And education, important in their self-management and their support and empower the patient to avoid unnecessary ED visit and how they can use their family physician or their respirologist and other community access they have. And then refer to pulmonary rehab. And, it's evidence-based and reduce long-term, reduce readmission if they're enrolled in pulmonary rehab within 30 days. So unfortunately, it's a huge problem for us. And, I'm going to talk about it in a few slides. So the referring pulmonary rehab and integration of home health and virtual tools that I'm, going to talk about. So this is and then if their patient is not confirmed and, it's a room for us to confirm and risk certify the patients in our COPD clinic. So these are some of the things that we are hoping to achieve in their transition of care. So to prevent readmission and improve outcome. So, and then another huge part of it, addressing comorbidities and especially in cardiovascular risk. So because if you think about those patients are older, they are same risk factors, they are older, they are smokers, from COPD, the air pollution. Most of them in their age 60s and up, they have other disease like similar to risk factor for cardiovascular disease like hypertension, dyslipidemia, or diabetes. So I think these COPD and cardiovascular disease or share their risk factors and their pathophysiology, some of those causing inflammation, oxidative stress, and causing endothelial dysfunction, and similar to that, and endothelial dysfunction in the cardiovascular. So there are data. If you looked at the study and look at the hazardous ratio within 30 days in acute coronary syndrome, all cerebrovascular disease like stroke, heart failure, arrhythmias, and all-cause mortalities are like in pretty high, especially in first 30 days. Look at the hazardous ratio for acute coronary syndrome, 3.74, and then stroke 2.46, and heart failure 6.81. And all-cause mortality is 9.26. It's a huge impact on those patients. If they exacerbate, they're high risk of having this. So preventing this exacerbation of COPD is a huge, and this is a large cohort study. And if left is unadjusted hazardous ratio, and it's a composite cardiovascular outcome. But on the right is a adjusted outcome, but you can look at it in, its first 14 days and first 30 days, the hazardous ratio is high. And then, and then by the end of the year, still is 1.84 of composite hazardous ratio of cardiovascular outcome. So a lot of people are looking into this and, definitely need some further evaluation. If they are exacerbated, they are high risk, they might need some, stress test and other workup done in an appropriate patient. So it's one thing that, maybe needing to look into it. Especially if they are heart failure, they're going to have a shortness of breath. The high risk of they coming back with a heart failure within 30 days is high. So optimizing, heart failure management and CVD management on those patients is a huge as well to prevent readmission. And their anxieties and depression, mental health, it's also the huge. I'm not showing the data, but that's also so addressing the comorbid disease, and as in during that follow-up, and in the medicine clinic immediately or in the COPD clinic, it's a huge part of the care management. And then, as you know, the smoking cessation is huge. So I'm going to skip that evidence, but I'm going to focus on pulmonary rehab. So if you think about pulmonary rehab in our system, it's only less than 1% of patients can have access within 30 days of discharge. So even though it's evidence-based in our system, it's unfortunately that patients can have their pulmonary rehab. So what options are available for us? In the era of digital and technologies and AIs and virtual models. So what are some of the options to in-person rehab? What else we can do? Because it's definitely underfunded. And so I'm going to talk about some of those community-based models and some virtual models currently look into it. One of the community-based model, it's called Inspired Canada. It's actually in a Halifax and nurse-led model with some advanced care planning actually improve some of those outcome of those patients. And then I'm going to talk about virtual pulmonary rehab programs, some gaining grounds and some data is available. And inhaler education to the pharmacy-led program, and it's collaborating during the COPD clinic and so on, improve their inhaler techniques and compliance. So this inspired COPD outreach program, it's a combined program from team nurse practitioners and nurses and RT and home care So they focus on patient-centered care and their self-management, educate their patient about the COPD, inhaler technique, and in a pulmonary rehab. And they talk about advanced care planning, severe code status, and palliative medicine referral. So they were able to do everything in as a program, and which reduced their 60% reduction in the ED visit and 50% fewer hospital day stay. And according to them, it's a scalable and cost-effective. Whatever the money spent in the program is actually reduce the cost of, healthcare because of you preventing their hospitalization and they are staying in the hospital less, 50% less. So you're improve their improve the outcome, improve their health system efficiency. So this is one of the models, and we can look into that. And then smartphone application-based pulmonary rehab. There are some Cochrane's review. One of the articles published in Thorax, a few weeks ago, pulmonary rehab. It's pretty much similar outcome compared to center-based in terms of the exercise capacity, their quality of life, but definitely superior to no rehabilitation within 30 days of their readmission. So basically what they did is like a 15 to 20 minutes unsupervised manner exercise program. It's focusing on muscle strength and balance and immobilities and it gives a virtual and instruction and video tutorial. Once they're done, they'll enter their scale of difficulties. Once it's entered, the program is actually will depend on their severity, adjust their next training program. They have like, I think 200 programs like similar to this inbuilt. It actually not only theory, it gives a relaxation techniques, breathing techniques, and meditation and coaching and everything. And what they did is it's impressive. And you can see in this graph, so in the y-axis is cumulative exacerbation, and here is in a week. The intervention as a dot, and control is, you can see the exacerbation is reduction. It's wider, they are continue to be on that program. It's doable. So I think there are people looking into further way of approaching some of those barriers to our patients. And hopefully, it'll be available for us. So, and then, digital tools and monitoring. It's not for everyone. I think patient need to have some, digital health literacy, and some available funding, some remote monitoring apps available, kind of breast mat for like our COPD patients. Sorry, for the OSA and sleep apnea, but Propel Health, some of the apps available to actually track their compliance and early symptom trackers so that you can figure out they are flaring up and act on early so that they don't need to come to the emergency room or department or admission. As you know that it's already there for in our diabetic patients, and their continuous monitoring of blood sugars and so on. So I think the people are looking into some of those for COPD patients as well. So there are more to come. These all to improve and to early detection and preventing their exacerbation. And because we know every time when they exacerbate, they decline in lung function, the mortality goes up, their risk of other, cardiovascular risk, and their life expectancy is going to be short. And then what is oxygen and NIV? So the oxygen, everybody knows that so oxygen is evidence A. And clearly, if they are needed, they need to be discharged from the hospital in patients. So I think we all do their oxygen assessment before discharge. And another thing that we, non-invasive, it's for selected patients. They have like frequent readmission, at least 2 readmission within the last year. They have stable, they have persistent hypercapnia. I'm not talking about the acute hypercapnia. when they come to a COPD exacerbation, that has a different story. And NIV helps their work of breathing, gas exchange, and prevent them less intubation. So that is definitely, we all do them. But this is just talking about preventing their readmission. If they are persistent hypercapnia and stable after discharge, 2 to 4 weeks time, and this is one of the things that we may be able to assess in your COPD clinic, and they have a gas and they are persistent, they have symptoms still, they have hypercapnic symptoms, then they are appropriate to have them at NIV. I'm going to show some data on that. So basically, the patient with chronic hypercapnia labeled as CO2 more than 52, history of at least 2 acute hypercapnic respiratory failure within the last 12 months, and their confirmed daytime PCO2 is elevated. They have persistent symptoms of hypoventilation, like morning headache and fatigue, and so on. It's better to rule out COP or OSA, but I think it's not necessary in our certain category of patients. The trial is a hot HMV trial, is a home oxygen therapy and home mechanical ventilation trial. It shows, a reduced, you can see here 12% reduction in patient with non-IV compared to 33% in control. The IPAP levels are high, and hazardous ratio is 0.24. So this is a brief summary. What evidence are to reduce mortality in patients with COPD? Again, triple therapy, we talk about smoking cessation, pulmonary rehabilitation, and long-term oxygen therapy as an appropriate patient and non-invasive, and some lung volume reduction, either surgical, some valves, and things like that will improve some of those mortality. But at least certain things are available for us. And also, we need to think about in a patient, centered care and equitable care in, immigrants and newcomers and indigenous peoples are high risk, and also those who have it low socioeconomic status and health literacy and language barriers are a huge part of the problem in our population. So I think the access to those resources for their language is important, and to the physician, those speaks, their language might help. So those are part of some of those challenges we have in our system, in our care around in Scarborough. So the recommendation, for me, I think when we think about discharging patients and think about all those things that we talk about in their checklist and whether those are able to optimize, not like just patient is ready to discharge because of they're not wheezing or they're able to be enough oxygen. I think the inhaler techniques, there are other aspect of comorbid disease, whether there's a component of heart failure that we optimize before discharge, and close follow-up with family physician or medicine clinic, and hopefully the COPD clinic, and access to care within pulmonary rehab and home-based program, so we can think about in our system whether that's what feasible, and hopefully there virtual billing codes and funding for pulmonary rehab, either is app-based or home-based program. Hopefully this will help in moving forward, in some digital care. So I think in summary, I think COPD management is evolving, and it'll be a huge burden in our system moving forward in next 5-10 years as the COPD population is growing and the readmission rate. So think about evolving care and including triple therapy, coming up soon for the biological and digital care, and personalized treatment given biomarkers, specifically eosinophil count, and excluding other possible diagnoses like asthma, then there's an entire different beast of treatment, and heart failure, cardiovascular risk, and so on, and equitable and access to care. to have an COPD initiatives and a bundle of care. I think that's all I have. And thanks for listening. And if there's any question. Yeah, Alex, I think your hands are.
Thanks, Narushan. Great talk. Interesting data about the mortality benefit of BiPAP in some of these patients. And I was just curious, in terms of navigating funding, when you spoke about the equity piece, is there OHIP-based funding for BiPAP for COPD or OBP?
Yeah, I think there's vent pool. There are patients that, qualify for vent pool, then, it's funded. So I think I had able to, get one patient and there are few readmission in multiple hospital and ICU stay and everything, and he's actually started in BiPAP and last 3 months he's actually stable in outpatient. So there are options available for NIV, but definitely not everyone. And, it's very selected patients are benefit from NIV, non-invasive ventilation.
And I guess further to that, what kind of turnaround, even best case scenario for getting a patient access and a machine?
So this
We
patient
tend
got
to see patients who come back again and again and never get it, but I suspect they're the outliers. Sorry. Yeah.
Yeah. So I think the particular patient, I think, I was able to get it for in 2 days through the vent pool and they delivered. But, it's a lot of information that needed, and you write a letter to them to say that it's really needed. And, so you can get it as soon, possible, but definitely not everyone. But I think it's really important for those patients who really need it.
Thank you.